Edition of the Urology Journal Club podcast. We're going to consider 4 papers today, and I'm sure the first paper, which was a letter or rather an editorial comment in European Urology, will raise some eyebrows. It's called the Tacito trial, and it uses fecal microbiota transplantation for patients with metastatic renal cell carcinoma. So this is the first of its kind, and the fecal transplant involved taking donor stool from patients who were super responders to the typical first-line treatment of pembrolizumab plus axitinib for metastatic renal cell carcinoma. So a fascinating concept, and it appears to be that the microbiome is restructured based on this fecal transplant, and that is through immunological mechanisms are theorized to have more efficacy in terms of efficacy for the cancer patient. So they never quite reached statistical significance, but there was certainly 70 versus 41% of 12-month progression-free survival. And the other findings were equally striking, that the median progression-free survival was 2 years versus 9 months, with a hazard ratio of 0.5 and a response rate of 52 versus 32%. So really quite startling findings. The authors also make the comment that standardizing super responder donor stool and the scalability thereof may be challenges for this treatment, but still, what an unusual form of treatment. The paper is also from the European Urology, and it looks at 2 trials related to cytoreductive prostatectomy in the presence of low-volume metastatic prostate cancer. Now we know that there is guideline backing for the use of metastases-directed therapy for oligometastatic disease, and that comes from the STAMPEDE trial in patients who received primary radiotherapy. But as I recall from previous discussions, there's never really been compelling evidence outside of small series to support cytoreductive prostatectomy. And there was also concern that such trials would never be done because of the complexity of these kind of trials. So the first trial they mentioned was 119 men, mostly who had prostatectomy, and this was a negative trial, but it was powered for feasibility. It used old-fashioned bone scintigraphy rather than PSMA PET, and it predated the inclusion of androgen receptor blockers systemic therapy. The second trial was 132 men, and here they gave surgery plus best systemic therapy, cut the 5-year cancer-specific mortality from 23 to 13%, so hazard ratio of 0.39, a striking outcome really. But it was stopped short early because of the poor accrual for this trial. There was about a 42% adverse events. So I think that the jury remains out with these 2 conflicting trials, and the authors conclude by saying there are 4 ongoing phase 3 trials that should hopefully settle this question. The next patient looks at the question of active surveillance for intermediate risk prostate cancer. It comes from the British Journal, and this is 18-year real-world data from a Winnipeg series, 500 men followed up for 4 years across all the NCCN risk stratification. And as you'd expect, the treatment-free survival of patients with on active surveillance fell from 84% with very low risk all the way down to 21% who were unfavorable intermediate. So reassuringly, despite a fairly relaxed real-world biopsy schedule, in other words, not as intensive as perhaps some of the protocols suggest, the overall metastatic progression was only 2.7% and cancer-specific mortality of 1.25%, so a very low problem for patients during relatively short follow-up of 4 years. And those who did run into trouble were concentrated almost entirely in the unfavorable intermediate risk, where it was as high as 7% of metastases. favorable intermediate risk disease tracked closely with low risk outcomes, which is interesting. This cohort's intermediate risk classification leaned heavily on grade rather than PSA and had higher tumor volumes than other cohorts, yet still showed excellent safety in the favorable risk group, reinforcing that surveillance can be considered for favorable intermediate risk patients, even if it's not the most intensive follow-up schedule. Lastly, staying with the topic of active surveillance, we're going to look at something that has always been of curiosity to me, the role of multiparametric MRI in active surveillance. And I think we're still waiting for more concrete guidelines to support its use. Not to say that it hasn't been used for years in that role. Can MRI then replace active surveillance biopsies? And this was called the MAST trial, and they enrolled 250 low or favorable intermediate risk men for annual MRI plus biopsy for at least 4 years, and biopsy regardless of the MRI findings. So by 36 months, 38% of the patients had grade progression, and PIRADS 4 and 5 independently predict grade on the next biopsy. So that was then 23% versus less than 5% if there were no suspicious lesions. I think we kind of expected those findings. However, the sensitivity of detecting progression fell over time, and over 2/3 of rising PIRADS scores were false positives. In other words, not backed up by a biopsy. An MRI-only strategy would have avoided 45% of biopsies, but unfortunately would have missed 32% of progression events, confirming that biopsy in a confirmatory role and remains important. So missed progression rates fell sharply after 1 year, which is also interesting, suggesting an MRI triggered approach becomes reasonable later in surveillance once early high-risk features have been excluded. I think that makes common sense. If you've got a worrying thing early on, rebiopsy, but perhaps the role of MRI can increase over time. So MRI, in conclusion, adds real predictive value, but should be informed when to biopsy, not to replace rebiopsy altogether. So thank you for your attention. Look forward to meeting again in September.